look at this fantastic panel we have here. So today we are going to talk about how data and AI, and it's really a privilege to be here with you, how data and AI can really help us reimagine the way we deliver health and care. In fact, if we look at the scientific innovations we saw in our past years, sorry, the slides are not moving. The what? Down. Okay. If we look at the scientific innovations over the past decennia, we have made tremendous progress. We have extended our life expectancy by tens of years, and most of these gains were thanks to the advances in cardiovascular medicine. At the same time, we have this convergence since a few years of technology innovations, and they allow us to really rethink and re-engineer how we deliver health services. We can now bring them to where and when people need them, even in their living rooms. That doesn't sound too bad, does it? But still, we see that cardiovascular disease remains the leading cause of death. And I don't have to repeat that here or give you any numbers, but 1 in 3 of all global deaths is caused by cardiovascular disease. That is far too many with all the evidence and the advances we made in cardiovascular care. Look at the numbers for Europe, for example. A pure 300 billion direct cost on cardiovascular disease, not to speak about the millions of lives lost and many of those prematurely. We need to go one step further. We need to understand what truly drives our health and what truly drives cardiovascular health, because we know that only 20% of our health is driven by the care we access. All the other 80% is driven by the underlying conditions in which we are born, we live, we grow up, and we age. And these social and environment conditions, they lead to these striking inequities like a difference in life expectancy for a baby born in one area of New York City, with that 12 years life expectancy difference with that of a baby born the same day in the same city in another area. We need to challenge that reality. We need to really understand what drives cardiovascular outcomes. And that is the opportunity we have today. By living in this data and AI-driven era, we can use those capacities to now finally understand the social, environmental, economical determinants that we don't understand well enough yet. And that's what we have set out to do at the Novartis Foundation with our initiative, a public-private partnership, AI for Healthy Cities, which we run with the cities of New York, Singapore, Helsinki, Basel, and Lisbon, where we bring together data from the health system with data from all these health influencing sectors, be it the housing sector, the food sector, transport sector, education, workplace, you name it. All the sectors that influence our health, we bring the data together and let the machines tell us what are the worst or the best combinations for our cardiovascular health. And New York is the first one delivering some results. Most of the cities will read out their results this year, but I can already share this from New York. For example, we brought together all of the US data, publicly available data on all of these underlying social determinant sectors with Microsoft, our partners Microsoft AI for Good, and we looked at whether that could predict the situation or the prevalence of hypertension and diabetes in New York City per census tract. And it perfectly predicts. What it's most important here in this first analysis is that we demonstrate that 70% of all diabetes prevalence is totally driven by social determinants. 70%, reaffirming this older evidence of the 2080 rule. And even in that, the top 3 determinants did most of that prediction. So it's all about low level of education, needing food assistance or public assistance, having no access to internet. These 3 drivers predicted more than 70% of the diabetes. And we can now deliver the city authorities in New York more precise data per census tract. What are the 3 leading social determinants of health that they should act upon if they want to improve cardiovascular outcomes? And this now allows the city not to continue these blanket approaches for food assistance or any other assistance. They can pinpoint their resources and tailor their planning to where it may have the biggest impact on the health of the largest number of people. So this is now the promise of what we can do with AI for healthy cities. You can inform the local city authorities where to allocate their resources to which places or population groups. In New York, it's going to be place-based because the data are census tract-based. In Singapore, Helsinki, it will be population-based, subgroups, because we have individual data on these sectors. And this is, in fact, the beginning of, sorry, I always push the wrong button. This is the beginning of precision population health. But to make precision population health a reality, you need to have very strong public-private partnerships. Look at the fantastic group our team has put together in the city of New York for the first part of the analytics, in fact, the research. We work together with the city authorities, obviously, but with several universities in New York and Microsoft AI for Good. Well, Cornell, NYU, and UCL London is doing our qualitative surveys to combine the quantitative insights also with lived experiences so that we don't forget anyone. And then to translate this into action, because that's the goal of AI for Healthy Cities, we need to bring together a much larger group of partners, not only the academics, but also the implementers, the health systems, the primary care systems, and many community-based organizations, too many to mention here, but it's a huge partnership we have built in New York City to translate all these insights into action, because that's what is precision population health in reality. So let me now briefly touch on some other use cases for AI in health, because obviously population health is not the only use case for AI in our health systems. In fact, I go back to a working group that I lead in the Broadband Commission for Sustainable Development. I lead the working groups on health and digital health and AI for health. And we looked at what are the top 5 use cases for AI in health, and population health is obviously the first one. We've seen examples like AI for Healthy Cities, but obviously it was very useful in the pandemic time as well, as you remember. The second use case that we know best now is R&D, how AI is incredibly advancing the discovery of new drugs, but also accelerating the development of new drugs, with making our clinical trials more efficient. The third use case is obviously in clinical care, and we will hear more about that in our panel. But there it started with improving and making our diagnostics, specifically those based on images, making them much faster and more accurate in clinical care. And now it goes towards delivering services in a very different way. Like, for example, Mayo Clinic is testing how, or validating how, nurses plus AI outperform doctors in many specialists. And this may solve a lot of the shortages of skilled health workers around the world. The fourth use case are the direct patient-facing solutions. And this is about helping patients to make more, to take more accountability for managing their own health, self-care or information awareness to patients. You have seen a lot of examples of that in the last years, I'm sure. And the last use case is making our operational workflows in the health systems more efficient. And that doesn't only mean to translate the processes into AI. It also means revising overall the processes so that we can transform our health systems from being these reactive care systems that wait for people to get sick to become proactive, predictive, so that they can become preventive and keep people healthy. We then translated all of these findings into a roadmap for countries to assess where they should invest in to accelerate their readiness to deploy AI in the health systems. And that roadmap is based on 6 pillars. First and foremost, governments have to invest in the skills and the data science capabilities of their populations, their workforce, including the governments themselves. Secondly, obviously, the infrastructure has to be there, both on the connectivity, knowing that still 1/3 of the world is not connected to the internet, but also on the infrastructure of data, looking at the most advanced countries with one single data platform that combines all data sets from all sectors. These are the gold standards we should all aim for. The third area where governments have a real key role to play is obviously to put in place the governance and regulatory systems so that we can both keep the people safe and the data safe and make sure that we don't integrate biased information in our solutions. The fourth pillar is that everyone developing AI solutions in health should take into account the end-user feedback before they even start designing their solution, because without that, you won't get to scale. And you won't get to scale either if you don't take into account how you are going to integrate the AI-driven solution in the workflow of the providers. You have to lessen their workload, not increase it, because then it wouldn't work. The fifth pillar is obviously partnerships, and there it is really crucial for governments to stay in the driver's seat of determining which AI-driven solutions are responding to the priorities they face. If that is not the case, if it's not a needs-driven solution, it won't get to scale either. And the last pillar is obviously they have to think of new business models, because many governments around the world, specifically those in low and middle income settings, would not have the infrastructure, the financing capacities to build this totally full-blown data system and infrastructure to use the data. So this is crucial to start thinking about other ways of funding the readiness of countries to improve the rollout of AI in their health systems. We have translated this, this report is available on the website of the Broadband Commission for Sustainable Development, obviously, but we also translated it in a self-assessment tool for governments to assess which of those pillars they still have to invest if they want to advance on that maturity roadmap towards rolling out AI in health. And that is freely available on the website ai.novartisfoundation.org. So let me end there by saying this was why the title of my talk, which I didn't say in the beginning, was No Data, No Health. Without that, we won't get there. So let's take advantage of living in this era of data and AI to make sure that we use data to understand what drives our health, to make the decisions in policy and roadmaps towards better health in populations, to make it a given that governments use data-driven decision-making, which is not the case at the moment in most of the world. And let's use the power of AI to really advance towards precision population health, because only then can we have an opportunity to set very bold targets, like, for example, getting to the target of eliminating heart attacks in the next generation. These conversions of scientific and technology innovations can help us get there. Do you believe this is possible? We are ready to try it out. With the first city who wants to take this ambitious goal with us, we will demonstrate that this is feasible for the next generation. Are you ready to test it with us? Thank you. So now, yeah. I always push the wrong one. So let's take this one. Let's move to my fantastic panel here with this introduction on the different use cases of AI very briefly. But maybe present first Professor Giulia Bielicki, who is the head of the the Pediatric Research Center in the University of Basel, and who is also a full professor at St. George University in London for pediatric infectious diseases. Hilal Lachouel is the Research, Development and Innovation Advisor to the chairperson of the Qatar Foundation, and is also a professor in neuroscience at EPFL here in Lausanne. Joe Beaufort is a clinical professor in global health at the New York University School of Global Public Health, and also past president of the International Society of Urban Health and of the New York Academy of Medicine. And Dr. Chris Kramer, I don't think he needs an introduction, is the president of the American College of Cardiologists and head of cardiovascular medicine in University of Virginia. So as I introduced you last, Chris, maybe I start with you. How do you see in cardiovascular medicine, as an expert in this area, how do you see the revolutionary take AI can bring to how we address the problem currently in the clinic?
Yes, we're using AI in cardiovascular medicine in so many ways now. I'm going to spend much of my time focusing on its use in diagnostics because my particular expertise is in cardiovascular imaging, and AI is making inroads in every aspect of cardiovascular imaging. But in general, AI is affecting also our ability to prognosticate in patient populations by taking large data and making groups into clusters that have certain characteristics, groups of patients with heart failure. And then when you have those clusters that have particular characteristics, you can really pinpoint focused therapy based on those clusters, and those clusters are clearly identified by AI. But really I want to focus on diagnostics and how AI is revolutionizing their use. So I'll start with the simplest diagnostic in cardiovascular disease, and that is the electrocardiogram. So groups have used AI evaluation of thousands, hundreds of thousands of ECGs to pick out patients with heart failure that either were undiagnosed or unrecognized. And then on top of that, particular diseases such as hypertrophic cardiomyopathy disease, 90% of those patients have an abnormal ECG. Lisa Sahlberg from the Hypertrophic Cardiomyopathy Association is in the audience and knows that finding these patients is critical because it's a underdiagnosed disease. So if we can use the electrocardiogram to find these undiagnosed patients, it's incredibly important. Moving on to more advanced types of imaging, start with ultrasound echocardiography. So AI has been used to show that the computer does an outstanding job of measuring ejection fraction, the pumping function of the heart, which is prognostic and important to identify who has a reduced ejection fraction. And a computer can do it extremely fast with AI approaches and has an accuracy, receiver under the area under the receiver operating curve is 97% compared to a trained operator. So, but that's just ejection fraction. There's a lot of other measurements that echocardiography can allow: diastolic dysfunction, valvular heart disease. AI still has some work to do to get to the point where it can do a complete evaluation of an echocardiographer. We're not getting rid of echocardiographers anytime soon. So it's not replacing the physician, but it's enhancing the ability of the physician to make the diagnosis and also speeding up the ability to make the diagnosis. The other application of echo has been the group at the Mayo Clinic has used just 2 views of function of the heart by echo to identify patients with heart failure with preserved ejection fraction as identified by clinical means. So again, identifying unrecognized disease with AI approach to just looking at 2 simple image acquisitions. The next imaging modality I'll speak on is CT. So CT, coronary angiography, or actually just chest CT, AI approaches to identifying patients with unrecognized coronary artery disease, because calcification of the coronary arteries shows up on every type of chest CT. That is the single best screening technique for coronary artery disease that we have in cardiovascular medicine. And so millions of chest CTs are done around the world every day, and in many cases, the coronary calcification is ignored. So if it's been shown that if you apply AI to identifying coronary calcification on lung scans or what have you, that improves the identification of coronary artery disease, as well as a study specifically using AI to do this shows that if you then inform they randomize to either inform clinicians about the calcium or not, the physicians who were informed increased their prescription of appropriate statin medications to lower LDL cholesterol, and the next step would be improved outcomes. Lastly, I'll turn to MRI of the heart, cardiac MRI. Clearly, AI has sped up the acquisition of images, but as well sped up the ability to analyze the quantitative data from the images. On top of that, AI is a group that I'm involved with, has taken images of patients with hypertrophic cardiomyopathy. In that disease, giving contrast shows scar in the heart, which is an important prognostic predictor of sudden cardiac death. You have to use contrast. The group at Oxford that I collaborate with has developed an AI approach that combines non-contrast images, two different types of non-contrast images, and what creates what's called a virtual native enhanced image. So creates an image that looks all the world like you gave contrast, and it's without contrast. So now you can do that type of imaging with AI and replace contrast enhanced images. So these are the kinds of advances in imaging that are happening very quickly, and it's getting faster. It's getting we're replacing some types of imaging, like contrast enhanced imaging, with computer-based approaches. Again, it's not replacing physicians. It's enhancing the physician's ability to identify disease, speeds up the process of making the diagnosis, and recognizing disease that otherwise was undiagnosed.
Amazing, and I very much agree with you. The AI is not going to replace physicians immediately, at least, but it will. Physicians who don't use AI will be replaced with physicians who do. That's what it is. Right? Who would still have a coloscopy without a physician who doesn't use AI? I mean, so we really have to think about it that way. Joe, if I may turn to you, in New York City, we have been combining, you have been like, let me start by that, the brain behind our work in cardiovascular population health in large cities. And in New York specifically, it was you who told us we can have all the data you need to understand these social determinants. So we came to New York, and it was worth it, as you can see, a lot of work, but bringing these data from health sector with all these health influencing sectors together now and applying advanced analytics and AI to that, it may become instrumental to finally turn the tide on cardiovascular disease and other chronic diseases also, because the same social determinants play there. But how do you see that this is going to change the way the city may address chronic diseases like cardiovascular disease?
Thanks very much, Anne. And I want to preface my remarks by describing that I am a primary care pediatrician who practiced in the South Bronx for about 15 years in my residency and post that, and it was very clear at that point in time that the broader determinants of health, especially poverty and other issues, were just incredibly important problems that I was faced with every day in taking care of patients. And I've been interested and followed developments really globally around this so-called, what have become called, thanks to Sir Michael Marmot in England with the Social Commission for the WHO, I've become the term social determinants of health. But one of the real things I've been working on, which I think provides context for some of the things we are being able to do in New York, is trying to be a bridge between the clinical community and those in government, both in public health, but also in these areas of the broader determinants healthy agencies that Anne mentioned, housing, transportation, and others. And I think the really big challenge we faced in looking at the question of urban health over the last 10, 15 years, when you see the word health in most global documents, most documents in the health sector, most people think of healthcare. You think of personal healthcare services. And we lose the other dimensions that Anne mentioned earlier around social determinants. And in talking with clinical colleagues who have begun to think about social determinants, they're quite aware of the fact that when they see patients in their examining rooms and then send them out over time back into the conditions that made them sick in the first place, in terms of the food availability or the ability to exercise or the sort of financial well-being or the quality of housing or transportation resources, the patients just come back and they're dealing with a part of the issue, an important part, but the usual response appropriately from clinicians, it's not my job. I see it, I'd love to do something about it, but I'm too busy doing what I'm doing, taking care of patients. And so part of the initial challenges are getting some of these large institutions, the names that you saw there, Mount Sinai, the Cornells, Columbia's, NYU's, to use their institutional authority to begin to use the leverage they have in communities to deal with local hiring, to deal with local economic development, other things that can really have an enormous impact on population health. But the one thing we've been missing in making the case, especially to elected officials, is really an evidence base for the degree to which health is dramatically influenced by these other sectors, as Anne mentioned earlier. And that's really been the exciting part of what AI has been able to kind of harness and pull together. So in New York, we have had the political support of mayors contextually anyway. I think the background for these and why this works in some cities and not in others is important. We had Mayor Bloomberg, who was called the public health mayor. A lot of his efforts were in labeling and smoking, sort of the last mile on smoking prevention, dealing with the transportation sector, active transport, bike lanes, pedestrian walkways, et cetera. But when he moved on, he sort of left a legacy that was picked up by his successor, Mayor de Blasio, who emphasized the equity issues. A lot of the Bloomberg changes were in Manhattan, which is in many ways the richest of the boroughs, and so they were extended into the other boroughs, the 5 boroughs that make up the city of New York. And most recently, the health department, with whom Novartis Foundation, Anne and her colleagues have been working very closely, have revised a plan for Healthy NYC, which is revised about every 5 years, focusing on chronic disease prevention. And the priority of the commissioner is diabetes, but I think the very skillful dialogue has created a double focus on really sort of metabolic syndrome, cardiovascular disease, and diabetes in the NCD prevention work, knowing that the sort of classic 15,000-foot tobacco, exercise, diet are risk factors for all of these diseases, but then taking it down to a more granular level. So this has really kind of opened the door with a considerable amount of political support for bringing these two elements together. And I think the challenge is, with our clinical colleagues, is really helping the larger clinical institutions realize that they need to partner with community-based organizations who focus on exercise, community-based organizations who focus on tobacco prevention, those that focus on changing food patterns in communities, and really develop those networks within the communities they serve to provide both the services to the individual populations, but also to influence up in city government. So when we got to New York, and I'll sort of finish with this part of it, when we came to New York, we spent about 9 months actually getting access to the electronic health records in the public hospital system through networks that we had available to us because of the concerns of confidentiality. And we were concerned that we'd have to do the same thing with all the other agencies in New York, because we wanted to look at what are people saying in their interviews. They're being asked certain questions about how relevant social determinants are to their life in terms of food security, housing, do they have jobs, et cetera. And how much of that, first of all, is in the electronic health record, but then if we saw focuses on housing, which is a big issue, on economic development and others, how could we go to other agencies and get quote-unquote permission to look at their database in the census tracts that Anne described? And happily for New York, so much of the data from all the other agencies is publicly available. learning this thanks to some of my colleagues who do research in this area in New York City, that we didn't have to do that. We were able to really access it directly, and then through a lot of work with epidemiological modeling folks at my university and working with Anne's colleagues and colleagues at Cornell, really began use that electronic chronic health data from the clinical enterprise to match it with the data from other agencies in New York and begin to see those major social determinants of health that Anne mentioned that are dominantly the factors in putting people at higher risk for cardiovascular disease. So part of what we're looking at the next steps, thanks to AI, is really pulling together that data, showing that the evidence that people have been talking about in principle over a long period of time is in fact able to be developed and acted on, and using AI to really identify the target neighborhoods and places in New York in which those interventions can be designed with the clinical community working in partnership with nonprofits and with the other agencies in the city.
Thank you, Joe. Yeah, this is really the goal, to bring it to life and to reality. And this needs very strong partnerships, but that's the beauty and the fun around it, mostly. So Hilal, maybe I can come to you as you're sitting next to Joe, but in Qatar, you recently launched the Precision Health Institute, and you also recently launched with us the Cardio for Cities, the Urban Cardiovascular Population Health Approach in Qatar. And I wanted to ask you, because we are, as you know, we are aiming to make our Cardio for Cities a continuously improving approach. And with the precision health approach in Qatar, how do you see you can contribute to innovating in the field of cardiovascular health to make that precision health go one step further than we currently have?
Thank you again for the question and the opportunity to be here. I think for us, we see innovation at multiple levels that all intersect with AI. The first one is on data integration. And here, the idea is to be able to integrate health data from electronic health record, genomics, from wearables, with both social, behavioral, and environmental determinant of health. The ultimate goal is to develop models that are highly contextualized and dynamic and enable us to make decisions quickly, to understand where risks will occur, and why, and who's most affected, and what would be the best intervention strategies and how to optimize them. That's at one level, but innovations are only successful if they're relevant. So in that context, what we're trying to do for Qatar and the region is to make sure that these are relevant to the region. And by integrating into these efforts our unique genetic makeup, our unique lifestyle, cultural values, and also the urban infrastructure of Qatar and the region. And we see this as an opportunity for filling a gap in terms of data from the region, but also developing things that are locally relevant but could have a high impact. But from our perspective, innovation in cardiovascular disease goes beyond tools and data. It goes into changing exactly our approach to health, from an approach that's based on episodic disease management to one that continuously supports prevention, health, and wellness. And this is, again, where I think the AI and the collaboration with Cardio for Cities, it's been a huge enabling factor for this. Ultimately, what we want is to develop, predictive analytic, digital coaching, and AI-powered support system that will empower the individuals, healthcare providers, and the system as well. And finally, what I want to point out is these efforts and prevention must go beyond the clinic. Yesterday, during our WHF advocacy committee meeting, I learned for the first time we've been so focused on how to get people to embrace preventive, and then to realize that the clinicians themselves don't have time to emphasize prevention. And as somebody who suffers from cardiovascular disease, I see this myself. The focus is always on treatment. So addressing this requires sort of a holistic approach to innovation that brings all the stakeholders. And finally, what we would like to do is use the power of big data, wearables, to bring technology to homes. Ultimately, I think the most effective data are the ones that are going to be collected in the real environment and real lives of people. So in general, this is our approach to innovation. And we're at the early stage, but we're blessed by having strategic partners like the Novartis Foundation and our partners in Cardio for Cities, where we're able to leverage and benefit from all the work that's been done on the member cities. So,
thank you so much, Hilal. I very much admire and agree with your clear vision. It doesn't have to be only in the clinic that these things are happening. Obviously not, and Joe, you also make that point very clearly. It has to benefit everyone, the people, the providers, and the system has to improve with all of that. So very, very important. Let me come to you, Julia, as you are leading our AI for Healthy Cities in Basel. Here in Switzerland, we come back home. So Julia has had the brilliant idea to focus on the data from a pediatric hospital, from the biggest pediatric hospital, the only one in Basel-Stadt, but combining that with many other data sets in Switzerland, something that has never been done, by the way. And we managed to get data sets from federal level, from different school medicine, and now also from Basel region, so the two cantons come together, which is really fabulous. But in the specific area of childhood obesity, we were going to look at what are the real drivers of childhood obesity. I know this is a hot topic in the World Heart Summit here today and yesterday because of the annual report focus on obesity. But childhood obesity is extremely relevant in the world. I don't have to tell you where, you can see it everywhere you travel. It is not linked to one single area in the world. So how do you see, Julia, that with all these different data, and the use of AI, how can we really contribute to understanding the problem and then making those insights become reality as well?
Right, so that's a lot of questions, big topics. Just to say that I'm one of these clinicians who are still working every day with patients, so to me this is something that feels very sort of real. And all of the things that have been mentioned about, the pressures on time, etc., resonate with me also. In terms of the program that we're doing in Basel specifically, I think one of the interesting things is that we can actually, for the first time, exploit what you would typically in research try to eliminate, which is bias, because we're looking at a very, very local population. And we can actually harness that bias that you would usually mean that from an academic point of view, you can't make generalizable statements, to really make very local, to generate very local insights that will help us to improve how we manage this particular problem or how we address this particular problem in our region. So you have to understand that pediatrics generally very much is about preventive care. It's maybe one of the very few branches, maybe together with obstetrics, that really looks at prevention as one of its major topics. So it moves away from that primarily reactive model to a much more preventive model. Think about childhood vaccines, for example, from my own area of practice. As a very important tool, but I think the problem in terms of managing obesity and overweight is that we're really poorly targeting these interventions at the moment. This is something that we sort of take a blanket approach. We weigh and measure kids regularly. In Switzerland, we're very privileged because we can afford this, and also our families can afford it because of the way the health system is structured. But then in responding to that, we are actually again choosing very blanket type of approaches where we make offers that may or may not be taken up, and they're not really tailored to those risk groups, I call them risk phenotypes, being a clinician, but essentially these clusters or patients that are characterized by a certain cluster of risk factors, which would be a much more efficient and effective way of placing our resources. So that's really what we aim to do with our analysis, is to generate a very in-depth understanding of who we should be talking to. Is this going to be school districts? Is this going to be certain groups of families that share characteristics and maybe also have certain touch points in their daily lives, giving us an opportunity to intervene? And then, because I do a lot of interventional research in my other academic life, we're also in parallel trying to support our public partners in thinking about what could these interventions be. And again, they will both incorporate elements of AI, but also they need to be feasible. And so I think this is where bridging that gap, generating trust in these analyses and these approaches amongst our clinical partners, amongst our public partners, but also identifying some sort of bridging activities that will really bring this to the families with whom we work, is going to be absolutely crucial.
Thank you so much. And I believe the combination of clinicians and people looking at the population health level is really fantastic in this panel. I hope you agree with me, but we all talk about the same approach. We have to segment, to cluster people or population groups, so that we can better target our interventions, and we have to make our interventions realistic, feasible, so that they get integrated in the work and the life of people. So I believe the message is pretty clear about how incredibly useful AI is and will be in bending the curve on cardiovascular disease. So the overall goal is, like you were saying in the beginning, Chris, to get to these predictive analytics. Imagine we can predict who will be at risk before they have symptoms, detect them before they have symptoms, and make sure they don't get a cardiovascular risk factor. In fact, AI for Healthy Cities in Singapore is almost there. We have built a simulator that includes very simple social determinants and a few demographic determinants, and outperforms the Framingham risk calculator very far. So with that kind of non-interventional pre-screening, you can identify people who will be at risk in the future. And that is how I am a firm believer that combining that with the new therapies and approaches in cardiovascular medicine, we can get to eliminate heart attacks in the next generation. So I thank you all for your attention, and I would like to ask a very warm and big applause for my fantastic panelists. Thank you.